My name is Lauren Hickey, and I did my case study on a patient with traumatic brain injury. So, a definition of traumatic brain injury is a blow to the head or penetrating head injury that disrupts the function of the brain, and this may range from mild to severe. So, patients with TBI tend to have deficits with cognitive abilities, specifically information processing, attention, memory, such as working memory, short-term memory, and long-term memory, categorization, and executive functioning tasks. So Papan Thasu said that therapy demands should follow the patient's recovery pattern, and as the patient experiences spontaneous recovery and heals, tasks should increase in difficulty and focus more on executive function deficits. So that's exactly what we're doing with our client now. The patient is definitely experiencing some healing and spontaneous recovery. So week by week, we're increasing her tasks to become more executive function based and be overall more difficult tasks than she could have done at the beginning of therapy. So the patient I'll be discussing is PG. She's been diagnosed with a severe traumatic brain injury. She was not seen at our facility for initial injury treatment. Her and her husband actually found our outpatient facility doing some internet research, and she has been coming to us for speech and cognitive therapy for the past 3 weeks. So, the diagnosis. We know that the patient experienced a traumatic brain injury post-fall. Due to the patient's initial medical treatment occurring at a separate facility, we don't have access to her MRI and CAT scan results. However, her husband was able to give us some of that medical information. So according to the patient's husband, the head CT showed some small infarcts. Doctors were unsure whether or not these were resultant from head injury, or they were also speculating that possibly the patient had had a stroke and that was the cause of her fall. So she actually fell down the stairs, and they were unsure why that happened. So they thought maybe she had a stroke, which caused the fall and then the traumatic brain injury, but they're not sure. We did find out that the head injury was contracoup, mainly affecting the right hemisphere. However, we know that there must be some left side affectedness because the patient has a moderate to severe expressive aphasia, which I will discuss in this slide. So we conducted our own cognitive and linguistic evaluation. So we assessed her overall cognitive functioning as well as expressive and receptive language. So our results indicated that PG had a moderate to severe cognitive deficits as well as moderate to severe expressive aphasia. So we were able to determine this by her difficulties in confrontational naming tasks, divergent and convergent naming tasks, which showed difficulties with verbal fluency tasks and categorization. Her reading and writing were both impaired. Writing, although this one is a little bit tricky because she actually injured her dominant hand during the fall, so that also accounts for why she's unable to write. She has difficulty with sequencing, inferencing, problem solving, short-term working memory, and long-term memory. So she had difficulty with a lot of executive functioning tasks during the evaluation. So in addition to the objective results we obtained from the cognitive and linguistic evaluation, we also noted some subjective assessment results. So we noted that during conversation, the patient had very tangential speech. She would often go on tangents. She was unable to remain on topic during storytelling. She required cueing. Throughout the assessment to stay on task for the structured activities as well as the conversational speech. She exhibited difficulty with implied meaning. So she would often speak very vaguely, talking about he or she or they without really explaining who she was talking about, and expected the listener to understand everything she meant. She also presented with poor turn-taking abilities, and she was very impulsive with her speech. So she would often say things that were inappropriate and impulsive. The patient also presents with a flat affect. So she doesn't show her emotion very well, and the patient's husband describes that she has difficulty when assessing others' emotions as well. So the goals. The goals for this patient are to name functional items with 80% accuracy, requiring minimal semantic and phonemic verbal cues from the clinician. Another goal is that the patient will require minimal verbal cueing from clinician to remain on topic and on task throughout conversational speech and structured tasks throughout 100% of the session. The final goal is that the patient will utilize appropriate turn taking during conversational speech, given minimal verbal cues from the clinician, and 100% of conversational speech during therapy. So the rationale behind these goals. The first goal about naming, so the patient is required to name items with very high accuracy, about 80%, which is much higher than her initial evaluation. Her initial evaluation was maybe 20% independent with naming. So we decided to make it 80% given minimal cues due to the necessity and functionality of naming common items. So minimal cues will still be provided due to the increase on patient accuracy. So 20% to 80% is a very big jump, but we expect with spontaneous recovery and therapy that at the end of therapy the patient should be able to name 80% given minimal cues. So a study by LeBlanc showed that conversational discourse is related to language skills of confrontation naming and verbal fluency in conjunction with cognitive skills. So naming is very crucial to communication and higher level conversational discourse. So this is a very important goal for the patient. The second goal was about topic maintenance and turn taking. So it's very important for the patient to gain independence in these areas due to an inability for a clinician to follow her around and cue her outside of therapy. So the need for independence in this area is crucial for daily communication. So therapy then. This slide discusses therapy at the initial start of PG's therapy course with us. So initially we focused on basic naming tasks due to the moderate severe expressive aphasia that she presented with, and this was her initial chief complaint. So therapy focused on confrontation naming, verbal fluency tasks, and categorization tasks. We also included compensatory strategies, so teaching the patient how to utilize circumlocution and describing objects that she could not name. So the focus of this was to not only help her self-cue and come up with the name of the item by herself, but also to give conversation partners more of an idea of what she was discussing. So therapy now. The patient now has made tremendous gains with spontaneous recovery and overall healing. So therapy is now geared towards higher level functional tasks, including more cognitive therapy. So a study by Sacco et al. Revealed that communication and cognition are highly interlaced. Therefore, tackling cognitive skills in therapy will benefit pragmatic skills and overall communication abilities. So an example of higher level functional tasks utilized during therapy is that we will always begin and end with conversation. So during conversation, the patient will be cued for sustained attention, appropriate turn taking, and topic maintenance. So examples of some structured tasks include listing characters and emotions from short stories. So we'll read a short story to her and ask her how she thinks the characters felt, and then we'll ask her to explain why the characters felt this way. So this task not only tackles the emotion reading troubles that her husband explained she was having, but also it tackles the expressive aphasia. So her explaining why the characters feel this way is giving her some structure and some basically an expressive task. So a study conducted by Bosco, Angelari, Sacco, and Berra revealed that patients with TBI have difficulty with comprehension of conversational meanings and emotions. Therefore, this task is functional and evidence-based. So other structured tasks utilized include reading newspaper ads and picking out important information to answer questions. So we chose this task because of her difficulties with reading during the initial evaluation. And another task we utilize is remembering people's names while pointing to pictures of them. So we'll show her a sheet of paper with 5 people on it, and it'll have their names printed underneath, and we'll come up with some ways to remember these names. Then we'll take the paper away from her and give her just the paper with the pictures and no names, and she'll have to name all the people. So progress and outcomes. The patient is showing marked progress week to week. Therefore, our therapy process is ever evolving to meet the specific needs of the day. The patient expressed how she appreciates that therapy is now more functional in her everyday use. So the patient initially wasn't a big fan of all the naming activities, although we did explain to her how this was functional and connected to conversational speech. So now she's a little bit more enthusiastic about coming to therapy when we use the more realistic newspaper articles and naming of people and remembering names. So we've kind of figured out what works for this specific patient. The patient's healing process, as well as dedication to therapy and a supportive husband, have led to an excellent therapy process and great gains in both language and cognitive deficits. So the patient and her husband are both extremely enthusiastic about coming to therapy. The patient's husband always ensures that the patient completes her carryover assignments, and he also tells us how he incorporates some of the naming tasks into everyday situations. So, for example, he has her empty the dishwasher, and as she empties it, he has her name every single item individually that she takes out of the dishwasher. So it's really been a great experience working with PG and her husband. So here are the references that I used for this assignment. Thank you.